dear Chairman, ladies and gentlemen. Let me tell you something about a gastrointestinal complication in a patient with diabetes mellitus. Why in diabetes mellitus we see, I think that it's, yeah. We see that every 10 seconds, 2 people develops diabetes mellitus in the world. We know that diabetes is divided into basic types. It's type 1, type 2, and type 2 is formed by 90% of people who have diabetes. And the International Diabetes Federation suppose close to 500 million people have diabetes worldwide. It's unofficial. But official, approximately about 390 million. It's also the worldwide cause of morbidity and mortality, and also is associated with many serious complications. The most important are cardiovascular, then neuroendocrine, and gastrointestinal. The EDF, it means International Diabetes Federation, estimates that in 2014, diabetes-related health expenditures amounted to 11% of total health spending on adults, and as we see, it's also a great economic problem. I have mentioned some gastrointestinal complications, and these complications are often caused by abnormal gastrointestinal motility, which is a consequence of diabetic autonomic neuropathy. Some studies have indicated that diabetic autonomic neuropathy is linked to the, at first, duration of diabetes, especially in type 2, and poor blood glucose control, especially in type 1. Epidemiology is unclear, but we can say that abnormal motility is mentioned in case of diabetes mellitus from 50 till 75%, and delayed gastric emptying varying from 30 to 60%, and enteropathy, it means decrease or increased colonic time, transit time with diarrhea or constipation. Diarrhea is from 4 to 22%, and the prevalence of constipation approximately from 20 to 40%. There are parts of gastrointestinal tract which are affected with this neuropathy. At first, esophageal and reduce lower esophageal sphincter, which the clinic unit is reflux disease, then reduced fundal relaxation, and it means delayed gastric emptying with gastroparesis, nausea, vomiting, and in large bowel it means increased colonic transit time with constipation or decreased, and it means diarrhea. How frequent are these gastrointestinal symptoms in diabetes? Constipation approximately about 30%, reflux disease about 20%, dyspepsia 15%, and abdominal pain and fecal incontinence about 10%. As we mentioned, and as I have shown you on the previous slide, abnormal motility of the esophagus is 50 till 75%. It means reduced number, amplitude, velocity of peristalsis, increased spontaneous, spastic, and repetitive contractions, appearance of multi-peaked contractions, then impaired esophageal transit scintigraphy. But what is most important, as I have told you, reduce lower esophageal sphincter pressure. It means for the patient's reflux disease. One USA study reported that this prevalence of reflux symptoms in type 2 is approximately 40%, but some Asian studies show that this number is not so high, about 80 to 25%, but correctly we have to say that the prevalence of GERD is relatively uncommon, lower in Asian population, for instance, than in Europe and USA. What are the potential risk factors? There are some controversial facts, controversial views. common risk factors like obesity, hypertension, dyslipidemia, but also neuropathy shows that they are not the great and the main player of the field of this problem, and also some living habits like smoking and drinking. And what else? It shows that, and some studies suggest that some psychological, psychosocial, and psychiatric factors are the most important player in the field in this problem. For instance, generalized anxiety disorder was present approximately in 15% of patients with diabetes, and also some lifestyle factors, habits may be connected with this problem. When we have to conclude the esophagus and the problems of gastrointestinal motility in esophagus, the prevalence is really of GERD in type 2 higher than in other adults. But no difference in pathophysiological factors such as peripheral neuropathy and metabolism syndrome was found in DM and reflux patients. It means that some psychological, some psychiatric factors and lifestyle habits factors can play a great role in this topic, and for that reason further study and efforts are needed to explore deeper the potential risk factors for the higher prevalence rate of reflux disease in DM patients. Gastroparesis is another important clinical unit. We know that the main cause of gastroparesis is diabetes, especially diabetes type 2, and seen up to 60%. The main symptoms are nausea, vomiting, pain, bloating. But what is very important, there are some changes in drug absorption, then food retention with increasing of bacteria, toxins, production of fermentation products. It means hypermotility, and for the patient it means diarrhea. Very shortly, to pathophysiology of diabetic gastroparesis, it's autonomic neuropathy, loss of nitric oxide, increased oxidative stress, loss of interstitial cells of Cajal, smooth muscle atrophy, and loss of macrophages expressing heme oxygenase. Epidemiology, the ratio female and male are 4:1. We can find that delayed gastric emptying in common functional dyspepsia is from 20 to 40%, but close to 70% in diabetes type 2. The symptoms I mentioned: stomach bloating, heartburn, weight loss, acid reflux, swelling in the abdomen. And what is also very important in this fact, that this gastroparesis is connected also with severe complications like severe dehydration, malnutrition, then with growing of bacteria, it's formation of bezoars, and also with rocking on rolling sugar blood levels, and also with decreased quality of life. Diagnosis is done by ultrasonography, ultrasound, by barium X-ray, and the gold standard is gastric scintigraphy, gastric manometry, electrogastrography, or upper endoscoping indeed. The treatment consists of nutrition therapy to tighten glycemic control is the most important thing, prokinetic agents, antiemetic agents, and other motility. I would like to mention these modalities later. The drug armamentarium consists of prokinetic agent, dopaminergic agents, serotonergic agents, motilin agonist, antiemetic agent, or psychotropic, in some cases, psychotropic drugs. There are some new or other agents like motilides, CCK antagonist, anodonors, ghrelin, or 5-HT1 agonist. The treatment of symptomatic gastroparesis consists of other therapeutic modalities like endoscopic treatment, botulinum toxin injection, or gastric electric stimulation, gastrostomy and ionostomy placement. There are some alternative ways of treatment like ginger or acupuncture without any basic evidence and surgical treatment. There is an algorithm for treatment of gastroparesis. At first, we have to do endoscopy. Why? No, because we have to exclude serious organic disease. Then gastric emptying test, then in failure, diet modification, in failure at prokinetic, in failure at antiemetic, in failure at neuromodulator, and the end of this therapeutic steps is surgery. When we want to conclude the topic of gastroparesis, gastroparesis is a syndrome characterized by delayed gastric emptying in the absence of mechanical obstruction. Diabetic gastroparesis is the main cause of gastroparesis. Scintigraphy is a gold standard for diagnosis. The treatment includes nutrition therapy, metabolic control, and prokinetic agent, and we also wait for the new prokinetics, and there are other possibilities to treat as a endoscopy, as a surgery to treat the gastroparesis. And the last one is large intestine with constipation and diarrhea. It's constipation, then also in sometimes diarrhea in case of ischemic colitis, because ischemic colitis is too high in a patient with diabetes mellitus type 2. Neuropathy damage the motility, and megasigmoid syndrome, it means colon dilatation, neuropathy, and the paralysis of ganglia. And what is the most important, this syndrome imitates acute intestinal pseudo-obstruction. It's a bad prognosis, and therapy is not, we are not satisfied with the therapy of this syndrome. Steatora, more frequently postprandial, and they appear at night, rarely fatty, watery, and abundant. This is the cornerstone, we can say, of therapy of all complications, also cardiovascular, neuroendocrine, also gastrointestinal complications of diabetes mellitus. It's the last algorithm of American Diabetologic Society, and we can see that the main statue is glycolated hemoglobin A, where it's under, it's a monotherapy. When it's higher, it's a dual therapy, maybe triple therapy. When this level of glycolated hemoglobin one is up 9%, and also there is the possibility to add insulin therapy. There are some conclusion remarks. Treating gastrointestinal autonomic neuropathy is a challenge. To achieve good metabolic control in diabetes and keep long-term, a combination of changes in lifestyle and pharmacological treatment is necessary. This is most important. Achieving near normal glycated hemoglobin significantly decreases risk of complication. However, only about 50% of diabetic patients reach their HbA1 target. Lifestyle modifications and metformin are the cornerstone of the initial management of type 2. However, increasing insights into the role of specific mechanisms involved in the neural control of intestinal motility and good brain communication have the potential to result in new therapeutic options targeting specific mechanisms beyond those exploited by current treatments. And indeed, of course, the good cooperation, or excellent cooperation between gastroenterologists and diabetologists is needed. Thank you for your attention.
Martin, thank you for your exact and useful lecture. Thank you for saving time for us. We are a little bit out of time. We have possibility for one question from auditorium. Professor Lukáš.
Lukáš from Prague. Interesting lecture, congratulations. Martin, I would like to ask you, do you have any personal experience with the direct gastrostimulation in those patients suffering from diabetes gastroparesis?
No, I have no experiences with direct stimulation, but I have some experiences with excuse me, with insertion of botulotoxin to pylorus. But it's not so good. Approximately about 50, maybe 60% are prophylactic with this therapy.
Thank you, Martin. Do you have a question? No. Thank you, Martin, for your lecture.